No conflict we had. Previous studies have reported that nerve-sparing surgery contributes to recovery of both erectile and urinary functions after radical prostatectomy. However, for patients who don't mind post-operative erectile function, we sometimes wonder whether nerve-sparing surgery should be performed for recovery of urinary functions. From the beginning, background of patients with and without desire for erectile function recovery may be different. So, in the study, we focused on patients without desire for erectile function and studied whether nerve-sparing surgery is beneficial for them or not. According to the patient's will to attempt penile rehabilitation after radical prostatectomy, we were divided into the patient into two groups, Group A with desire and Group B without it. UCLA-PCI or EPIC were used to evaluate those functions. Multivariate analysis was performed to identify predictive factors associated with recovery of urinary and erectile function. Finally, differences in the factors between the groups were compared. Results. At first, the background of the patients differed between Group A and B. Group B without desire had elder, low sexual function score and low rate of using nerve-sparing surgery. So these groups are different groups. Then this slide shows significant predictive factors for urinary function and erectile function in both groups. Nerve-sparing surgery was a significant predictive factor for urinary function recovery in Group B, but only at 3 months. However, we think this period during the 3 months after surgery is very important because these times they are returning their work. They may lose their jobs because of urinary incontinence. So, in conclusion, even if patients have no desire for erectile function recovery, we consider that nerve-sparing surgery should be performed for patients who desire early recovery of urinary continence. Thank you.
Are there any questions from the audience? Some radical prostatectomists out there? Well, are we radical prostatectomists? Not really.
Well, I observe mainly the complications of radical prostatectomy. So in that respect, I'm committed to radical prostatectomy that my colleagues are performing. Could be a message of this trial that whatever the wish of the patient is, that you with nerve sparing, you like in the supermarket, it's 2 for the price of 1 that you can get urinary recovery and potential erectile function recovery by performing nerve sparing.
Yeah, maybe nerve sparing surgery is necessary for patients, for everyone, but for patients who don't mind urinary incontinence, not have a work they don't need. Mm-hmm. But basically, we consider all patients should be performed nerve sparing surgery except risky cancer.
Yeah. What puzzled me a little bit is, but you probably it could also be that I misunderstood, that you put unilateral and bilateral nerve sparing in one group. Is that correct?
Yeah, this study is together one group.
Yeah. And did you do a sub-analysis of bilateral versus unilateral?
Pardon?
Did you do a sub-analysis between unilateral versus bilateral?
Yeah, different. But these small groups, I cannot find difference. So
because that seems an important point. Quite often you can have it now with MRI. It's more possible to precisely localize the cancer element, that then there could be a clear reason to not spare a nerve at the site where the tumor is in a close vicinity. So if the outcome would be that unilateral versus bilateral is similar, should be more relaxed to offer one nerve for cancer optimal cancer treatment rather than urinary continence preservation. Any other comments from the? Oh yeah, there's a question there. So.
Letitia de Kort from the Netherlands. Thank you for this presentation. Although it's a study on functional outcome, maybe it's also important to look at oncological outcome, because that's necessary to weigh whether you can do a nerve-sparing surgery or not.
Yeah, pardon.
That you also should include in such an analysis the oncological outcome, because indeed nerve sparing could endanger.
Outcome, okay, thank you. Didn't differ between the nerve sparing group or any group.
And you presumably mean including tumor-free margins?
Yep.
The association with blood loss, how do you explain the association with blood loss?
More blood loss shows better recovery. Because I think one reason is because no coagulation cause more blood loss. No coagulation damage nerves. So
more diathermy.
No coagulation. Less coagulation cause better outcome.
Yeah, that sounds plausible.
Okay.
Thank you very much.
Thank you. Move on with the next one.